Hey, future respiratory therapists. Today we're going to be talking about distributive shock. Distributive shock has multiple different types. There's septic shock, which is the most common one, commonly known as sepsis. There's systemic inflammatory response syndrome, or SIRS. There's anaphylactic shock. There's neurogenic shock, or endocrine shock. So I wanted to make sure that I went over those. We don't go into too much detail in this video about the different types, but I did break down like the hemodynamics, ABG anomalies, vital signs, but a lot of the way that they present is pretty similar. So I mainly focused on sepsis, just because that is the most common one, and across the board there's a lot of similarities there. So yeah, so before I go through these exam findings, I kind of just want to break down sepsis and what sepsis is. So sepsis is a life-threatening organ dysfunction resulting from dysregulated host response to infection with severe circulatory, cellular, and metabolic abnormalities. So what does that mean? Well, basically, sepsis is a critical condition that's often life-threatening. It can often start as a bout of pneumonia, and it kind of, when left untreated, it gets worse, and can ultimately be life-threatening. It ultimately is a bacterial infection that the body will sometimes try to fight off, and it'll cause multi-organ failure if left untreated. This occurs because the body is struggling to fight off the infection, and it's not getting proper tissue oxygenation or tissue hypoxia and proper oxygenation to the tissues. And so there's decreased oxygen to the organs, and after an extended amount of time of the vital organs not getting proper oxygenation, it causes them to shut down. And so oftentimes we'll see the body try to fight off the infection by producing a fever. So the body will have a fever. That's why it says fever on there, because it's struggling to fight off the infection. And then in turn, we'll see oftentimes a low blood pressure and an increased heart rate and increased respiratory rate. Once the body reaches that, once it's trying to compensate and it's no longer able to compensate, it will often, we'll see a switch, and the body will no longer be in a fever state, but it'll be cold and clammy. So yeah. So this slide just defines what distributive shock is. It's severe peripheral vasodilation, also known as inadequate tissue perfusion with decreased blood flow to the heart, brain, and kidneys. For this imaging slide, we just have some different methods of imaging that are often used for distributive shock. So the first one, I've actually never heard of this, and I thought it was really interesting. It's called RUSH. It's basically just a rapid ultrasound assessment that helps determine cardiac function and fluid status, and also it can determine or help determine the cause. We'll often see echocardiograms used as well, just to distinguish the injection fraction. So typically, if we know the injection fraction, we can kind of know how the heart is doing. and what level or degree of severity the heart is at. And then x-rays are always useful, and those can kind of show us if there's something severe like a tension pneumo or pneumonia or something else along those lines that is contributing to the patient's symptoms. For this hemodynamic slide, we can see that pretty much everything is going to be markedly diminished when it comes to sepsis. This slide just kind of breaks down how with SVR and the EA, why they are both markedly diminished due to sepsis. And then I've just included in here neurogenic shock, just because the hemodynamics are a little bit different when it comes to neurogenic shock and anaphylactic shock. Primarily with anaphylactic shock because the CVP will be normal or increased. And that's just due to how the body is affected by anaphylaxis versus sepsis or neurogenic shock. So when it comes to pharmacologic meds, these are not meds that we're going to be giving as respiratory therapists, but it's still good to know. Primarily with hypotension, you always want to give fluids. So we see here that it lists IV fluids or crystalloids, and that's just kind of to reverse the hypoperfusion. We also want to take into account vasopressors as well as vasopressins. I admit I tend to get these confused, but one is to increase the MAP and the SVR, and then the other is to increase cardiac output and blood pressure. So those are all very important, and they kind of play a key role in adjusting hemodynamics and helping the patient be hemodynamically more stable. So with mechanical ventilation, primarily what I could find was lung protective protocol, or like ARDSNet protocol, more or less. So I put on there the tidal volume, 6 milliliters per kilogram. Prone positioning can be really important, especially for patients that have sepsis-induced ARDS. And then when it comes to mechanical ventilation, like the parameters or the modes of ventilation, we want to make sure that we're thinking about the blood gas. Patients with sepsis, they tend to be metabolically acidotic, and so having those parameters that are more helpful for balancing a blood gas, like ACVC or ACVC plus, can make a big difference in the patient's outcome. So the main key for this slide was just that when it comes to positive pressure ventilation, we want to make sure that we really keep it at a minimum PEEP, and we titrate the PEEP down depending on the patient's well-being. Kind of similar, in my opinion, to like the ARDSNet protocol. But yeah, just we want to make sure that the patient is not having any overdistension of the lungs, as that could, cause damage, permanent damage to the patient. Lastly, here are all my references. Obviously, I didn't come up with this information on my own. Thank you so much for taking the time to watch this video, and have a good day.